Hi, my name is Attaya Suvannasankha. I am a myeloma physician at Illinois University School of Medicine and Simon Cancer Center. I also practice at our Indianapolis VA Medical Center. So I'm excited to share initial safety and efficacy result from a clinical trial called MagnetisMM-30. The clinical trial is exploring two different classes of drugs but use them together in a patient with relapsed refractory multiple myeloma. One drug is called Elranatamab. It's already been approved as a single agent in patients who have failed at least 4 prior lines of therapy, including immunomodulatory agents, proteasome inhibitor, and also the CD38 antibody. Well, there is an important message in that we would like to understand how to use them by boosting efficacy, but also be able to use them a little bit earlier in a patient's journey. So the drug works by grabbing onto the T cell and actually pull them together to attack the cancer cell. That class of drug is called bispecific antibody. We're using it together with a pill called Iberdomide. The drug is not yet approved, but it is a new class that is improving efficacy and also ability to activate T cells comparing to the immunomodulatory agents. So in this case, it would appear that we're combining things that are helping each other out on how to kill the cancer, and we're exploring them together. In the clinical trial, there are 2 parts. The part 1 is what we call dose escalation, which is really to understand the right dose and also toxicity of the combination. And then the part 2 is going to expand to larger number of patients. So I'm going to report the data from the part 1 only. Patients would classically receive what we call step-up dosing of this elranatamab. They start with baby dose, middle dose, and then they receive full dose. Once they complete that step-up dosing, they start on the combination. The elranatamab is a standard dose. It is 76 milligrams subcutaneously once a week. And then the iberdomide, this capsule, is a 1 milligram. That's sort of a dose that's commonly used across multiple clinical trials. Because there were some side effects occurring in the population, we also have the data from what we call a dose -1, a little bit less intense dosing. Elranatamab, same dose, but it was given every other week rather than weekly. And the dose of oral iberdomide is the same. So the whole idea is we're going to look at the dose-limiting toxicity, meaning any adverse events, any side effects, and we're going to also look at the overall response rate, complete remission, and so on. So far, there are 22 patients that have been enrolled. The first group of patients were 13 patients, and then the lower dose, we had 9 patients on the study. Now, although, in theory, patients could have had relapsed refractory myeloma and have failed at least 1 line of therapy and then could go on, it turned out that the group of population that went on were people who have failed more things than what's required. About half of the patients are triple-class refractory, meaning that they've already progressed across all of the 3 different classes of drugs. About 86% of them progress on the last therapy that they've received. We also had people who had disease outside of the bone marrow, what we call extramedullary disease. That's a group that has very difficult to treat problem, and either single agent just didn't seem to quite get them the similar response comparing to people who don't have that kind of bad behavior. We also include about 40% of people who had this bad sort of genetics, the bad changes that we know predicting the cancers to be more aggressive. So the long and short story then is overall response rates actually totally about 95.5%. So quite impressive. We didn't see that kind of response with single agent elranatamab. Iberdomide has been kind of combined with a variety of things. The drug's not yet approved, but just across the board, this 95.5% is also looking better comparing to some of the iberdomide studies. Now, I was mentioning that there are actually 2 different doses, the dose that we start with and the lower dose cohort. Response is the same. Actually, the second cohort had 100% response rate. The response occurred pretty early. A little over a month into the treatment, you'll know whether the treatment actually worked or not. And so far, we already had about 45% of patients who have achieved complete remission or better. Now, we know that with these classes of drugs, you sort of need the response to improve over time. Now, the average time on the treatment is 7.8 months. So some patients are going to actually still be in the early part of the treatment. What we're also encouraged to see is the side effects that we see are kind of similar to what we would have imagined happening with either drugs. So we don't see those cytokine release syndrome, the fever, dropping the blood pressure, oxygen change, or the neurotoxicity that occurs with the bispecific antibody. The percentage of when this happened and the severity is pretty similar to what we had seen with elranatamab alone. Now, so what are the key side effects that we picked up that make us needing to reduce the dose? It's actually a drop in neutrophils, certain type of white blood cells. So when people have a drop in neutrophils, they have increased risk for infection. And because of that, some patients are receiving growth factor support to boost up their neutrophils. So when we were comparing the doses that were delivered in the cohort 1 and in the lower dose level, actually we were more successful at delivering the dose in the second cohort. And when it's easier for patients and also response rate is the same, that's actually very encouraging to us. So now the study is still ongoing. So we'll be recording update side effects and response in these patients that we're reporting already, but also there'll be more patients being enrolled to the part 2, and that is going to explore kind of dose optimization. Now that we know what could work, we're going to try to figure out whether we can adjust it some more to make it easier and also to maintain the efficacy. Now, people are always wondering, do you need 2? Is one better and then you save the other one for later? Well, we're going to also have what we call correlative sign studies, where we're going to look at the T cell function in those folks who are getting both drugs, because we have data for what their T cells, their immune cells look like when they were on one drug alone. And if this pills adding on to elranatamab would boost T cell function, then we hope to be able to show it based on this extra lab analysis as well.
If our videos have helped you in any way, and you're able to, please consider making a donation to help us continue this important work.
Your gift will go 3 times as far when we reach $500,000 by the end of the year.
Every contribution, big or small, makes a difference, and we're deeply grateful for your support.